And tonight we're going to be talking about all things that you are concerned with. So tonight there is no one overall topic, exhaustive debate, question and answer are happening. Tonight we're going to open the phone lines, ask you to call us with any COVID related query that you have specific to the health aspect, the science aspect, the medicine aspect, medical aspect. And our experts who are here will try and answer those questions. I also will focus a little bit specifically about the double mutant, which even the WHO now has said is a variant of concern. Double mutant, which is first spotted in India, is now also being found in other countries, transmits very, very fast, infects people very, very quickly. We're going to talk about a little bit about that and how much of concern it still is. We will talk about vaccines and whether the existing vaccines do work on the double mutant, and if that will be a big challenge going forward, that as the virus evolves, more mutants come out, will the vaccines also have to constantly evolve and change? We're also going to talk about this black fungus infection and the rising cases. Now, what are the signs there? What happens? Why does it happen? What can be done? How big of a concern is it? I have many questions about it as well. So we'll ask those questions to the panelists. We're also going to talk about the misinformation that is spreading and try and dispel some of that. There is so much of conversation which is happening about steroids being used for COVID treatment. When should you use the steroids? To what extent should you use it? Are there now instances that we are looking at where unabashedly, just like it was with remdesivir at one point of time, that everybody is simply prescribing these steroids? I'm sure in your circles you've heard many examples. Many of them are concerned as well about the use of them. So these are some of the things that I wanted to talk about. So without wasting any more time, let me say good evening to the panelists who are joining us right now. Dr. N.K. Arora, Executive Director for INCLEN, Chairman of the COVID-19 Working Group, National Technical Advisory on Immunization. Dr. Rajesh Parekh, Director for Medical Research at Jaslok Hospital, author of the Vaccine book, joins us this evening. Dr. Sanjay Pujari, Director for Institute of Infectious Diseases in Pune, member of the National Task Force, joins us this evening as well. And Dr. Harsh Mahajan, Founder and Chief Radiologist, Mahajan Imaging, President for Nat Health, also with us this evening. Thank you so much, and for doing this, where you've also agreed upon for us to take questions from viewers and help them with some of the answers. Let me actually start with you, Dr. Arora. We've had conversations in the past about the double mutant, but again, since it's become such a big talking point, even the WHO is not speaking about it. Other countries have begun to trace this as the India variant that they need to keep a track on and study. What more can you tell us? What more do we know so far about this double mutant?
So this double mutant, we can also call 617, B1.617. And this mutant, the major characteristics is that it is much more infectious, 50 to 70% more infectious as compared to the other coronavirus which was circulating in the country. And that's why I think the evidence is, in a very lay sense, that last year only 1 or 2 people in the family would get affected. Today, if it enters in a family, almost everybody gets infected. So it's highly infectious. So that the spread is there. And I think a very important reason for the driver of the current upsurge, that we reached almost 400,000 cases every day, was primarily driven by this variant. The second thing is, this variant is overcoming some of the other variants, so-called triple mutant, and in other parts. So every day, a lot of variants keep on coming up. So I think our viewers know it very well. But real variant of concern is that one which survives and keeps on moving and has a high transmission. So that is what is this variant. 2 other important points. One is our vaccines are still effective against this variant. Covaxin and Covishield. Covaxin particularly studies have been done and which shows that there is a slight decrease in the neutralizing capacity, but still it works. The second thing is that our current diagnostic mechanism do pick it up, and therefore there is no issue in terms of diagnosis. And the third is that we need to, the whole world is really kind of scared about this variant because the way it spreads, it can overcome all kinds of the processes and procedures. And that is why there are such strict or stringent travel restrictions from India. And people are very meticulously trying to look for it. I just saw that first case of corona in Australia has occurred, and he traveled to India 2 months ago. So that is the intensity with which people are trying to look. And one of the important reasons that why the world wants to help is that it should not spread, because this is, I would say, very malignant in terms of spread and the way it has put all our health systems into disarray. I'll stop at that.
Yes, absolutely. And let me also bring in Dr. Pujari here, because Dr. Pujari, from my understand that from the first time that something like this gets detected, it still needs a lot of study to see and figure out whether or not it will be of any significant consequence, or will it just phase out, or will it become one of those dangerous ones like the UK variant or the Brazil variant, and now this one. But now, how much longer and what kind of studies will we need to actually understand when it comes to the fatality of the double mutant, not just the transmissibility?
So right now, as far as stringent studies are concerned to assess the severity of infection associated with this variant is available only for the UK variant, which is supposed to be a little more severe as compared to the wild type variant which was there previously. For other variants, we really don't have strong data to suggest that severity is more. For that, obviously, you need to do studies, both basic science studies to look at in vitro ability to cause cytopathic effect, as well as clinical studies where you try to correlate and compare the mortality with this variant versus the previous variant which is there. So obviously this would entail a lot of genomic sequencing to really identify which variants are in circulation. But at this point of time, we don't have strong evidence to suggest that this variant is perhaps more severe than the previous variant. Remember, one of the things when we talk about higher mortality is also dependent, or the rate of mortality is dependent upon the number of people also getting infected. So at one hand, we are saying that this variant is extremely contagious or more transmissible. So you would have more number of people getting infected. So obviously, even if more number of people getting infected, even if it is 1%, the absolute number of people who may have mortality because of it would be obviously higher. So absolute number is not the way to go. In terms of the number of deaths, you need to really have a good denominator and find out what is the case fatality rate. So essentially, this means a lot of good quality studies to be done both at the basic science level as well as at the bench, at the bedside level.
Okay, no, so fair enough, and that's something that we'll have to wait and see, and as the studies progress. But for example, a lot of people are asking a question: why are we seeing this entire scenario unfold about oxygen shortage? Why are we seeing more cases where people need oxygen and a lot more oxygen? Does that have something to do with the variant we're talking about, or is it simply now because more people are getting infected, it sounds like their intensity is graver?
Yeah,
Dr.
so
Pujari.
obviously the second aspect is obviously true. So that is very clear that more number of people are getting infected, so more number need hospitalization, more number are coming with severe disease, and obviously need more oxygen. So essentially that is entirely true. But the other aspect is whether you have severe disease in the same proportion of people as compared to the first wave, and whether that leads to higher need for oxygen or other kind of therapeutics is an open question still. We don't have evidence to suggest that this is more severe. Though anecdotal experiences, people say that you land up into severe disease within 3 to 4 days, etc. But I think we should not. We should wait for further systematic studies to really build a conclusion on that. But apart from that, it's really irrelevant, because even in terms of contagiousness, as far as any variant is concerned, and I'm sure you're going to have lots of variants which will be discovered in the time to come, the basic precaution measures remain the same. Whether it's the wild type virus or it's a variant virus, you need to really mask and do physical distancing, hand hygiene, and avoid crowded places. So it's very, very important to re-emphasize this. Irrespective of what variant is circulating, public health measures, getting a vaccine are extremely crucial for any kind of epidemic which can, or a pandemic which can be driven by any of the new variants that may exist or may come in the future.
Okay, interesting. Let me actually also bring in our other two panelists, and Dr. Parekh, bringing you in here. The other follow-up to this usually is, what about our current vaccines? Will they work? The two vaccines that we already have and the others which are there across the world, which we may have tomorrow, will they work as the virus evolves and these mutant strains, double mutant, triple mutant, emerge in our country?
Well, we can talk of what we've seen so far, Tanvi, and possibly conjecture a bit about what the future might hold for us. As far as the present is concerned, the different vaccines do seem to work against the various variants that are operational across the world today. One possible exception, of course, is a variant in France. It's not seen very widely, but that is able to dodge the antibodies in the human blood. But that's a rare exception. By and large, the vaccines are effective against the variants this far. But we must never forget, as I never tire of saying, that science is always 2 steps behind the virus. So the virus changes, mutates, we follow in its footsteps, and then it takes us a while to establish through genomic analysis, genomic sequencing, that indeed it is a particular variant which is responsible for a particular syndrome. But as of today, I think we can rest assured that our current crop of vaccines approved across the world are effective against the existing variants.
Okay, so that is good to hear. As of now, on what we know, basis that it does look like these are effective. Dr. Harshmajan, if I can come to you as well on this entire conversation about double mutants, because a lot of people are asking questions. How do we interpret when even the WHO comes out and says, okay, this is now a variant of concern, we need more information? Should we be stepping up on our testing, tracing, genome sequencing? Should we be doing it at an international combined level with some of the other countries? What is usually the process that's followed?
Thank you, Tanvi. See, a variant of concern is generally labeled, as it has been by the WHO, when either a new virus, a mutated virus, is more contagious, more virulent, or is more resistant to the vaccine that you have developed or to the treatment that you can give. And in this case, as has been said by the panelists earlier, it does appear that this is more contagious, maybe 60–70% more. And but about its virulence, we still don't know whether it's more virulent or less. We will come to know in time. Now, as regards, how to actually go about looking for it, we are able to identify it on the RT-PCR test, which comes positive. Of course, on RT-PCR, we can't say whether it's this variant or that variant. That can only be known by whole genome sequencing, which is what is being done. And you've rightly asked, actually in the UK, they've already sequenced so much that they've picked up over 500 cases with this mutant. And I would say very frankly that in India, we have lagged behind. The numbers that needed to be done as per the government's own calculation was 5% of all positive samples since the beginning of the pandemic, and we are way, way behind. Probably we've done 20 or 25,000 samples till now. And the only way to know and identify the mutations. And do remember that even in this so-called double mutant, there are subtypes that are already identified, and this will continue to mutate. Newer mutants will be found, but they can only be found if we step up the whole genome sequencing, and if we can actually become part of a consortium across the world. There's no harm in it. Ultimately, the entire globe is concerned about this variant, because just like the UK variant, this is more contagious. And that's why we are seeing this upsurge, this huge 4x number that we saw in the last few weeks as compared to the first wave. So we should, I think, in fact, not only we should, but we will be made to, work with other nations of the world and to step up the numbers, because within our country, we do have a capacity which is there, both in the public and the private sector, but probably we need to do much, much more so that we can identify the mutant and also its spread within the country and outside. It's already in 21 countries across the world.
Okay, in fact, let me bring in Dr. Yes, yes. If I can just bring in Dr. Arora on this. Dr. Arora, I think there is a larger consensus that we were slow in beginning setting this up and ramping up to the extent that we should have initially. But now, do you believe that India is doing enough of genome sequencing and following up on these strains to be able to share this information, not just internally for our policymakers, but also to the world?
You're absolutely right. We started slowly, and but today the processes and the whole the way things are being done they are more structured, strategic, because the purpose of doing genomic sequences, as just now, as I said, it is epidemiology. It is trying to look at the disease. How does it affect the disease severity? How does it affect the infectiveness? How does it affect the vaccine effectiveness? And how does it affect? So individual patients don't benefit from genomic sequence, but it is the overall policy environment which is driven by the genomic sequence. And we are well positioned. The second thing which is very important and which is being mentioned in passing, that every day hundreds and thousands of variants appear, but variants of concern are only few, and it takes 3 to 5 months to label a particular variant as variant of concern when it starts making an indent on one of those 5 issues. And our 617 is certainly has made the epidemiology different. We have seen such a massive supersonic outburst of the cases. Number 2, it has infectiousness is much higher. So in view of this, we are well placed, but as very rightly, there is a constant need for surveillance so that as new ones appear, one takes preemptive action at policy level and program level.
Okay, fair enough. Let me also actually now go across to Dr. Parekh on this. And Dr. Parekh, would you want to add your view in terms of the pace at which we are now sequencing and tracing, and if we need to step that up?
Yes, Tanvi, and they are two disparate, separate, though related questions. One, as far as the genome sequencing question is concerned, we are nowhere near the pace that we require. And although at present, genome sequencing may have larger implications, if in the near future, genome sequencing also becomes important for deciding the treatment options in an individual patient. It's possible in the days to come that we might see that certain variants respond to a particular line of treatment as opposed to others, but that's in the future. But the other question, which I think is far, far more important, is our testing, not genome sequencing necessarily, but testing overall adequate. As you rightly pointed out, it was slow to begin. I believe we're still slow. I mean, it's far more impressive than in what it was several months ago. But today, there are 90 countries in the world who are testing more rigorously than us. And to give you one example, the United States is testing 7 times the rate that we are testing. Now, it's a simple adage. The more you test, the more cases you will see. So if we were to extrapolate our testing rate, quite clearly, the number of cases is way beyond what we believe it to be right now. Another factor to be considered is the sensitivity of the RT-PCR, which is our gold standard in testing. About 35% of people give a false negative, which means that even if they're infected, they will appear negative. We need to factor that in while planning our strategy. And finally, Tanvi, there is some cause for concern about the distribution of these tests because they then tend to become a self-fulfilling prophecy. So let us see where this begins. The initial infections are in the cities because they are the gateway points. And so testing is high over there. As more tests are conducted over there, naturally you get more positivity. One tends to believe that the infection is largely confined to urban areas, but that's because we're testing more over there. And that in turn creates a vicious cycle of more testing in these areas, and therefore the belief that the pandemic is largely restricted to urban or semi-urban areas, whereas rural areas are safe. So then we fall further behind in our policies because we are not testing adequately in rural areas. So it's not just the number of tests that are being done, but also the distribution of these tests across various demographics and across the country, rural, semi-urban, urban. And finally, if I may, Tanvi, I suggest it's about time we changed our nomenclature, or at least the usage of descriptions for these variants. For example, when we call it the UK variant, it's only because the UK reported it first. But if we keep calling these as South African, Brazilian, and now maybe even the Indian variant, it isn't very encouraging for countries to report them immediately. And besides, it's biased. It is prejudiced to call the original virus a Chinese virus and attribute names. While technical names are, of course, complicated, but we can come up with better nomenclature than attributing blame to certain countries in the world.
Yes, well, on one of our previous conversations, Mr. Arora was kind enough to say, oh, remember it as Kadi number 617 and Kadi number 618. So at least I now remember 617 as the end for the double mutant case. But I understand what you're saying about attaching names of countries to it and whether that's the right way to go forward. Let me bring in a couple of our viewers who have queries. On the phone line, calling us from the national capital is Mr. Venugopal. Good evening. Go ahead, please. What would you like to ask?
Yeah, good evening. I got my first dose of vaccination on 1st of April, and I tested positive on 8th of April. So I have a doubt when I should get vaccinated for the second dose. That is my query.
Okay. Thank you for calling. In fact, the question that you are asking, many people are wondering right now. Dr. Pujari, would you like to take this one? Somebody who's gotten infected within a week of getting their first dose, what happens to them, to the rest of the, to the second dose then?
Yeah, so if you are infected post-vaccination, particularly within 1 or 2 weeks of receiving the first dose, you complete your acute illness schedule, you finish your isolation, and after that you can take your vaccine whenever it is scheduled as a normal second dose. So normally people usually get around mild disease or moderate disease, so they can finish off their isolation by 10 to 14 days, and the vaccine schedule is usually you can basically take a Covaxin second dose between 4 to 6 weeks, or the Covishield 4 to 8 weeks. So there is a broad window available there. So you recover from your illness, you finish your isolation, and whenever it is scheduled later on with a margin of 2 weeks, and 2 weeks for Covaxin and 4 weeks for Covishield, you should be able to take your second dose.
Okay, so 2 weeks for Covaxin and 4 weeks for Covishield, and there is enough window available there for, between the first and the second dose for you to go ahead and take it. So I hope that answers your question, Mr. Venugopal. Let me also say good evening to Mr. Anant calling us from Bengaluru. Good evening. Go ahead, please.
Good evening. Thank you very much. I think this expert panel's advice is really valuable to all of us. My question is with respect to the environmental spread of the coronavirus itself. Typically, spraying of disinfectants across the city and the hospital areas, namely the sodium hypochlorite, was actually carried out in the previous pandemic 2020 period. And now it is not being practiced as vigorously as required. What is the effectiveness to reduce the spread? Is it really advisable if the panel of doctors could advise our local administrative authorities on the spraying of this hypochlorite, sodium hypochlorite in offices, hospital spaces, and containment zones? It will be really helpful so that we can plan it across with the local administrative authorities. Thank you.
Okay, thank you for calling. Dr. Arora, would you like to take this one? Okay, we seem to have lost that line with him. Let me take it across to Dr. Pujari.
Okay, so the transmission modes of the COVID-2 virus has also evolved over the last 1.5 years as we basically have started understanding it. So previously there was a lot of emphasis on surface transmission, that is, droplet transmission on surfaces, and somebody handling those surfaces and self-inoculating themselves, and then respiratory droplets. Well, there is now large concern about airborne transmission, which is coming up, and including the Centers for Disease Control in USA have acknowledged that it is an important mode of transmission across wider distances. So that doesn't underemphasize the need to do environmental cleaning rigorously in all areas, even if it is home or workplaces. It's important that we do environmental cleaning quite rigorously. In terms of airborne transmission, there is now actually some view that it's better to be outdoors, particularly if you are able to maintain social distancing with masking, obviously, rather than being in closed congregated settings with improper ventilation. So last year, we have not been emphasizing on ventilation as much, particularly air exchanges in closed environments, or using filters if it is available for filtering air and putting in clean air into the rooms. But this year, this is evolving, and we have more evidence now to suggest that perhaps you should be looking at improving ventilation in closed settings. So most transmissions, actually, there is a study which suggests that most transmission happens indoors actually as compared to outdoors. But this is something which is still to come in guidelines. We are still basically very conservative in our approach of trying to immediately open up or something. But these are some important scientific advances that has happened, and over the period of few months you may be able to see this translating into practice as well. So this disinfection, I'm at least for environmental surfaces, I think should be done at this point of time till we have further stronger evidence to suggest that surface transmission doesn't really has a significant impact on transmission. Till that point of time, I think we should be able to support the use of environmental disinfection.
Okay, so until we have more evidence to say it doesn't help, let's continue with this. Dr. Parekh, would you like to also come in on this? Because, you know, ever since this whole conversation has begun and more studies have indicated that this virus is largely airborne. I know of people who've even, you know, asked this question that should we then keep ourselves shut in? Should we then not even open up our windows even at home? Because obviously at home you're not wearing a mask. And if you bring in more ventilation, then would that become...
Opinions on this surface cleaning? Of course, there has been more than one opinion. Recently, there has been data to indicate some hazards of the kind of agents that are used and sprayed across surfaces. So there is a rethink, and there's no clear-cut answer on that. But on the airborne transmission, I can talk to you because we were amongst the first people in the world, I can say with confidence, who wrote about airborne transmission. And this was in the book on the coronavirus, which we started writing in January and had it ready by February of 2020. In that, we wrote, I think, 2.5 pages on airborne transmission, citing by a scientist called F.W. Wells. This was published in 1936. I don't want to get into the details of this, but he did a fascinating study looking at the effects of humidity, of temperature and wind velocity, as opposed to gravity, in converting what was a droplet into wrote to the WHO. Some of them cited our work too, saying that we should consider it seriously, at which point the WHO says, well, maybe it is possible, but we don't think so. And then finally, data has emerged now that indeed, in certain circumstances, the virus is almost entirely, if not totally, airborne. So on that now, I believe the debate is closed. I believe it was an unnecessary debate because this was amply clear in 1936 if one had followed the historical data on droplets. I do believe that airborne transmission is a major factor, and that now is acknowledged by others as well. As to the ventilation part of it, again, 14 months ago in our book, we had recommended, in the light of all this, that it's good to have a lot of ventilation. We've recommended it at different places in our book, including during recovery, to keep the windows open, to keep the fans going, to let fresh air in and out. And I think that too is becoming now increasingly clear. And I had protested actually. I'm not sure if, while I was talking to you, but I do know I was vocal about pushing people back into their huts. You know, there were policemen outside of Dharavi, and the moment people came out, they were pushed inside. And at that time, and this is about a year ago, I had suggested that not only these people, but society in general would be safer if they were allowed outdoors rather than confined, closely closeted in indoor spaces.
Okay, interesting that you say that, and thank you for, you know, actually elaborating as well on this aspect. Before we take in more callers, I wanted to also touch upon the mucormycosis, which has become a talking point now, and of course, we've heard from the ICMR as well. This question has been now asked multiple times to them. But Dr. Harsh Mahajan, there is a lot of concern, especially amongst people who may have other comorbidities or specifically diabetes. What can you tell us about this? Is this a new trend, or are we just hearing about it again in larger numbers because, again, overall cases have gone up?
I think what you say is very right. It is because of the larger numbers, and also because probably the use of steroids has gone up. Also, more and more people are for much longer period in the ICUs recovering. And because of the use of steroid, as you know, the sugar level in the blood rises, and the diabetics, it's really become more like a tsunami where everyone is on steroid, and the glucose levels in the blood are very high. And apart from that, of course, those who have an immunocompromised system or who may be on drugs for cancer and other diseases, they are certainly more at risk. And it is because of the numbers that suddenly mucormycosis has come to the forefront, and the so-called black fungus in lay terms. And it was there earlier. We've seen it, when COVID wasn't there. It's not something new. And it is quite a devastating disease, and we need to recognize it early. The signs are pretty simple, starts with a nasal stuffiness. There may be swelling around the nose, around the cheeks, forehead, then pain. It may then there may be symptoms of from the vision point of view. You may see double. If it's actually much later in the stage of the disease, if it's gone unnoticed, it may actually burrow into the, through the skull into the brain and cause problems as a result of that. So even, people are known to lose a tooth or something because of this, especially of the upper jaw. So it needs to be recognized early, and especially in those who are more at risk. And then it needs to be treated very aggressively, including at times with surgical debridement based on the situation. And of course, there are antifungal drugs which are given, and they are given for a prolonged period of time. But the main thing is to recognize it very, very early. From they are more at risk. There is this fungus which is in the air. You inhale it. You're already immune compromised. You're on steroids. Your sugar levels are high. Your immunity is low, and this takes over, and this can be devastating. And the ICMR has brought out a very nice, I think, pamphlet on this, which, if followed, I think any patient or relative, as well as the physicians who treat, would be able to recognize this disease early. And if recognized early, it can be treated very, very well.
Okay, so the key there actually has to be able to recognize it early and react on time, so that you're able to treat it easily. And that's something I think as experts will obviously know, but you have to reach out to a medical expert to be able to see, for them to see this detected and treated on time. Linked to this also, there has been a lot of conversation, Dr. Sanjay Pujari, about the use of steroids, and in what conditions should they be used. And if we are now staring at a situation where it's just being prescribed at a just a larger mass scale as a simple COVID treatment.
Yeah, so far this my favorite statement is use the steroids in the right patient at the right time, in the right duration, in the right dose. This is extremely crucial. And right now, the evidence for use of steroids is very clear. You should use it only in patients who need respiratory support. If you don't need respiratory support, if you are at home, you don't need steroids. You just need monitoring. And as the oxygen level falls, for some patients, they get admitted, they need oxygen. That is where you use steroids. So that is the indication to start. We are seeing people self-medicating with steroids after they get a diagnosis, or they are started on steroids on day one, and this can be detrimental because studies have shown that if you use steroids earlier on, when you don't need oxygen, there is a risk of harm associated with the use of steroids. So that evidence is very clear, and globally all reputed societies, including the ICMR guidelines, the National Task Force guidelines, do not recommend steroids in mild illness. So it's only when you need oxygen, and when we talk about oxygen, usually these are hospitalized patients. So it's only under the supervision of the healthcare worker or a doctor that steroids should be initiated. The second aspect with steroids is the dose that is given. When we use steroids in COVID-19, it is used in a very low dose, and unfortunately, we find a lot of doses being used in this context, particularly very high doses. For example, the simple dosing regimen that is recommended is using a steroid called dexamethasone, only 6 milligrams. So that is the dose that is recommended. And if you don't have dexamethasone, you can use equivalent dose of that. The third important point is the duration. Because steroids are supposed to be used for only 10 days, or if a patient gets discharged earlier, you can stop steroids on discharge. What we are finding is patients are going home, they are continued on steroids, they have underlying diabetes, the sugars go haywire, nobody is monitoring their sugars, and then they'll end up with mucormycosis. So it's uncontrolled hyperglycemia because of steroids, which is the major risk factor. Why I'm talking diabetes as a risk factor is a major risk factor because the form of mucor that you are saying is the sinus involvement or the eye involvement is predominantly a feature of diabetics. While in other populations whose immunity is down, say transplant patients, it's the pulmonary system. So here there is clear epidemiologic link that this is predominantly driven by hyperglycemia, amplified by hyperglycemia means high sugars, amplified by steroid use, and this is very critical.
Which is why people who have a diabetic problem also have to be very careful of what is being prescribed to them when they get infected with COVID, because there's just like Dr. Pujari was mentioning, the usage of steroids has to be done in a very judicious and sensible manner at the right time in the right quantity as well. Let me bring in Parichai, who's on the phone line calling us from Mumbai. Good evening. Go ahead, please.
Good evening. There are two queries that I have. One is on the life-saving drug and the other is on testing. Now, the question of life-saving drug is, the DRDO drug which was in news recently. I believe that it has been tested, it has been using it. Why is the support of remdesivir, which is not an indigenous drug, still going on? And the second question is about testing. Something about Tata's developed Feluda test kit. Has that not been used? Why are we still reliant on RT-PCR and rapid antigen tests? Thank you.
Okay, two very interesting questions that you've asked. The DRDO drug, of course, that you are referring to has just about got its approval, emergency, not 2 days ago. So it will take time to come into the markets, and actually it's not the first Indian drug. We've, in the last few weeks, some more of these drugs have been given the nod to be used for COVID treatment. Dr. Parekh, would you like to take this query on?
Well, you answered the first question. So let me come to the second. But a partial answer to the first question would be some continuity of Dr. Pujari's excellent and comprehensive coverage of the use of steroids. There's just one thing I'd like to add to that. In all this, let us not forget that steroids are today probably the most proven, the most effective, the most time-tested of treatments for COVID-19. The WHO did a huge study, the Solidarity trial, which was published about 7-8 months ago. In that, they looked at various drugs, and including remdesivir and tocilizumab and a lot of other drugs. And they found the most effective drug across countries was steroids. Of course, as Dr. Pujari and you have rightly pointed out, they have to be given at the right time, in the right dose, and I might add, in the right place, which is the hospital. Because given too early, they may suppress immunity and allow, yes, in the hospital. They should ideally not be given at home at all. And also when we're looking at moderate, severely affected patients, they usually end up in a hospital, not necessarily in an ICU. About the testing component of it, as of today, flawed though it may be, the gold standard across the world to compare data is the RT-PCR test. Most important, the RT-PCR test has a very high degree of specificity. So what is specificity? Is how accurate a positive result is, and it's between 98 and 99% specific. Now, what matters is if somebody is diagnosed, they need to take forward calls regarding treatment and various other things, and especially, of course, contact tracing and isolation. The sensitivity is not so robust. There are other tests being developed, but until we find something which has an equivalent level of specificity and a far better level of sensitivity and a quick turnaround time, we are for some time, I suspect, going to be stuck with the RT-PCR test. But I'm aware there are tremendous things going on. ICMR has recently approved a test which actually has a 2-minute turnaround, but I don't want to talk about it unless it's in the public domain.
Okay, let's hope that it is out soon and we're able to get, access to it as well. Dr. Harsh Mahajan, would you also want to come in there? Because honestly, we've got a lot of queries about whatever happened to the Feluda COVID-19 test, which is supposed to be cheaper, India-made, faster alternative. Why is it not being used?
Well, I don't know the details of why it's not come into general use as yet. What I do know is that this is a test which was developed in Delhi at the IGIB, the Institute of Genomics, which is a part of the CSIR. And then it was the Tatas that were to bring it to market. And the pun was on Feluda. Really, why it's not come to market, I'm sure extensive trials must be going on. And till such time, Tanvi, you have to remember, we have to be very, very certain about, as Dr. Parikh said, the sensitivity and specificity of a test before it can come into the open market and be used for diagnosing disease. And I'm sure, despite the fact that things have happened very, very fast, in medicine, it still takes time. And probably that is where it is, and that's why we are unable to use it now.
Okay, thank you so much. And I just want to just point this out that, when there is something available which is credible, which actually passes all our tests and safety tests that have been done, then it will be available in the market. I don't think there is an intention of forgetting that something is there that we can use, but we're not using it, and we're running after international test kits or drugs for that matter. Just want to put it out there for our viewers to know that whatever can be used and is safe for use and does work will be at the right time then announced by our authorities as well. Medha Bhaskaran on the phone line from Bengaluru. Good evening, Medha. Go ahead, please. What would you like to ask?
Yeah, there is this medicine, steroid inhaler, budesonide. The Indian brand name is Pulmicort. I think it is used for asthma. Now, I read a research paper in Times of India saying that those who are in home quarantine can use this if they have little breathing difficulty. They can use this steroid inhaler on their own. And it has been proved useful. Is it true or false, or what is it?
Dr. Pujari?
Oh, yeah. So inhaled budesonide is an interesting molecule. There are 2 trials in the UK. One was a phase 2 study called the STOIC trial, and then one is a preprint called the principal trial. This both looked at using inhaled budesonide. Found was the duration of symptoms was narrowed down with use of inhaled budesonide. And in the principal trial, there was a signal, though it was not statistically significant, suggesting a delayed, reduction in the number of hospitalizations. But that trial is still not completed. They have to finish the 28-day follow-ups for all patients. So until that data is available, we need to be reserved the decision about whether it prevents progression. Because today the most important drug that you need to really talk about or we really need to research is something which can prevent people from progressing from mild illness to severe disease. That's the $1 million question. That's the $1 million drug that is really needed. And this is where many studies are going on to start treatment early, and inhaled budesonide seems to be promising. Now, even in the ICMR guidelines for treatment in mild illness, it is not recommended for everybody. It is suggested that you may use it based on the available evidence, but in consultation with your physician. You do a teleconsult with your physician, because using inhalers is also not easy job. You have to be trained in using inhalers, because you have to take a proper dose or when you use it. So it needs a little training as well. So on a case-to-case basis, yes, you can consider using it, but only after consulting your primary care physician.
Okay, thank you so much for taking that. I think it's been an extremely enlightening conversation, an interesting conversation, thanks to you experts who've taken the time out to answer our queries. I hope it's helped our viewers as well. We unfortunately have run out of time, but there were many more queries, so maybe we'll do another round soon in a few days and get more of their questions answered. But there you go, and some of the takeaways here. Whether it's any drug that is being prescribed or steroids that are being prescribed, you must be a little more aware and ask certain questions on why it is required, in what quantity, and if that is the right thing. It is becoming a big trend now that steroids are being prescribed in more than what is required number of cases. It's something like what we saw during remdesivir as well in the initial days. And of course, when it comes to a life-saving drug like that, it's difficult for people to ask questions. You're only going to go run around and pay what you can for that drug because your doctors asked for. So hopefully, there is some amount of moderation that happens even in prescribing of these. As far as the mutant is concerned, you heard the experts. We need to do a lot more of genome sequencing and tracking, but there is nothing right now that suggests that the current vaccines will not work. So don't be hesitant. Get out there and get yourself vaccinated whenever you can, when you get the slot, as per your eligibility, around the vaccination centers in your area. Thank you so much for joining us. Have a good night.